Hello, everyone. Welcome to another edition of Hematology and Blood Transfusion Science Lecture Series with Dr. Mary and Okafor. This is a YouTube channel where we discuss different topics in hematology and blood transfusion science. Thank you for being part of what we are doing. Thank you for subscribing to our channel. And if you have not subscribed yet, please, this is the right time to hit the button. Today, we will be discussing another topic, bleeding disorders. Remember, for some time now, we'll be handling topics under hemostasis, and today we will be discussing bleeding disorders. Learning objective. It is expected that at the end of this lecture, you should be able to describe the mechanisms of hemostasis and how their defects cause bleeding. You should be able to distinguish clinical features of primary versus secondary hemostatic defects. You should be able to classify causes of bleeding disorders, and you should be able to interpret key laboratory tests used in diagnosing bleeding disorders. And also, you should be able to outline general principles of managing bleeding. Let us start by defining what bleeding disorders are. Bleeding disorders or hemorrhagic diastasis are conditions in which there is an abnormal tendency to bleed, either spontaneously or in response to minor trauma due to defects in the hemostatic mechanism or in the hemostatic system. We have had lectures on hemostasis, and we talked extensively on primary hemostasis, secondary hemostasis, fibrinolysis. In that lecture, if you have not watched the lecture video, I would advise you to go back to our channel, Hematology and Blood Transfusion Lecture series. So, look for that lecture on primary hemostasis and secondary hemostasis. It will help you to understand what we are doing today better. Now, for ease of understanding, I divided stages of hemostasis into four: vascular constriction or vasoconstriction. We have platelet plug formation, or what we call primary hemostasis. And we have the third one, coagulation cascade or secondary hemostasis. And we have fibrinolysis or tertiary hemostasis. Now, a defect in any of these systems can cause bleeding disorder. A defect in any of these systems can cause disorder. Let us look at classification causes of bleeding disorders. Causes can be broadly divided into inherited or acquired, or it can also be grouped by which part of hemostasis that are defective. So let us look at the classification based on the part of hemostasis that is defective. Classification based on that is classification of bleeding disorders based on the part of the hemostasis that is actually defective. We have four different disorders, four different groups. We have vascular abnormalities. These vascular abnormalities, you can say they are structural defects or functional abnormalities of the blood vessels or connective tissue supporting them. When you have problems with, or structural defects with the blood vessels, if you may have tendency to bleed, and that is under vascular abnormalities. And we have the second one, the platelet abnormalities. This has to do with primary hemostasis, abnormalities in the primary hemostasis. The platelet abnormalities can be quantitative, that is what we call thrombocytopenia, or it can be qualitative, what we call platelet function defects. Okay, so when there is an issues with platelet, either quantitative or qualitative, that the patient or the individual will have tendency to bleed. We have the third one, a defect in the secondary hemostasis. A defect in the secondary hemostasis or a defect in coagulation factor. Different coagulation factor deficiencies can also cause bleeding disorders. Defects in coagulation cascade or missing on dysfunctional clotting factors, inhibitors, conditions that affect factor production or consumption can cause bleeding disorders. And we have the fourth one, fibrinolysis disorder. Fibrinolysis disorders. The fibrinolysis disorder, example, hyperfibrinolysis. Hyperfibrinolysis is as a result of breakdown, excessive clot breakdown. So classification based on the part of hemostasis that is actually defective are of four types. One, vascular abnormalities, platelet abnormalities, abnormalities that affect the secondary hemostasis or coagulation factor deficiencies, and the fourth one is disorder. Now, for the other aspects of classification or grouping or cause, it can be as a result of inherited disorder like inherited cause, or it can also be acquired. Okay, if it is inherited, that means it is passed down from generation to generation. It's a genetic condition, you know, having a mutated gene being passed down from father to the offspring or from mother to the offspring. And we have example, we have hemophilia. Hemophilia is a rare X-linked genetic disorder that can occur as a result of deficiency in coagulation factor 8, which is hemophilia A, or as a result of deficiency in factor 9, which is hemophilia B. Now, hemophilia is predominantly found among males because, as you know, males they have only one X chromosome, while females will have two. Therefore, females tend to be carriers, while males most times, once they have the defective gene, ends up expressing it. Okay, and we have the second disorder that is also inherited, bleeding disorder that is also inherited. We have von Willebrand disease. Von Willebrand disease is the most common inherited bleeding disorder caused by a deficiency or defect in von Willebrand factor. Remember that when we treated primary hemostasis, we said that von Willebrand factor is a very crucial protein in primary hemostasis, also even in secondary hemostasis, because von Willebrand factor is the factor that helps uh, platelet adhesion. Platelet adheres, when platelet adhere to the exposed subendothelium, it adheres directly to the von Willebrand factor. And also, von Willebrand factor, in addition to enhancing platelet adhesion, also is a carrier for factor 8. It protects factor 8 from degradation. Therefore, issues with factor von Willebrand factor causes bleeding disorder, and von Willebrand factor disease can affect both male and female. And when we have rare factor deficiencies, where an individual for some reason or in genetic mutation is having deficiencies in other clotting factors such as factor 1, factor 2, factor 5, factor 7, factor 10, factor 11, and factor 13. Then we have some bleeding disorder that are acquired. These ones are not inherited. They are not there before. But for some reason, the patient or the individual in the course of his life starts having this type of disorder. And then this type of disease or bleeding disorder develop later in life, maybe not due to genetic or inheritance. We have the liver disease. We all know that liver produces most of the clotting factors. Therefore, diseases such as cirrhosis can lead to deficiency in all the clotting factors that are being produced by the liver. And as such, the individual will have issues with bleeding. We have vitamin K deficiency. Now, there are some factors that are vitamin K dependent. Factors like factor 2, factor 7, factor 9, and factor 10. They are vitamin K dependent. So without vitamin K, these factors will not be able to function. And therefore, when an individual lacks vitamin K, there's a tendency for them to have deficiency in some of these factors, and that will lead to bleeding disorder. We have autoimmune disorders. Now, conditions where the body's immune system mistakenly start attacking clotting factors. Example, in where we have acquired hemophilia. Acquired hemophilia or platelets or immune thrombocytopenia. Now, when an individual develop autoantibody, his own antibody against his own platelet or against his own clotting factors, this can also lead to bleeding disorder, causing disorders like acquired hemophilia or immune thrombocytopenia. We have some medications like drugs, like anticoagulants like warfarin, heparin, antiplatelet agents like aspirin, clopidogrel, and that are designed to prevent clotting. And because in them trying to perform their function, they can increase risk of bleeding. Let us look closely at the bleeding abnormalities that has to do with the part of hemostasis. That's like we said, we have four: vascular abnormalities, platelet abnormalities, secondary hemostasis or abnormalities are abnormalities that has to do with coagulation factor deficiencies, and fibrinolysis abnormalities. So let us look at some of the diseases that fall under vascular abnormalities. This leads to bleeding because of the fragility or defect in the vessel walls. Often with when you with this type of uh, abnormality, you can do coagulation factors and you can do your platelet count. They will be normal both in quantity and quality. Therefore, showing you that the problem with the patient is having has nothing to do with platelet or coagulation factors, but except where there is cofactors, where those things are coexisting. So we have examples of vascular abnormalities like hereditary connective tissue disorders, Ehlers-Danlos syndrome. Hereditary connective tissue disorders, what we call Ehlers-Danlos syndrome. Now, this Ehlers-Danlos syndrome is just as a result of defect in collagen or supporting structures. It occurs as a result of defect in collagen or supporting structures. And with this defect, the individual ends up developing abnormally elastic skin, and this will affect the blood vessels and leading to bleeding tendencies. We have what we call hereditary hemorrhagic telangiectasia, HHT. Then this hereditary hemorrhagic telangiectasia is an inherited disorder that causes abnormal blood vessels formation, leading to fragile vessels that can easily lead to bleeding. Let us have a closer look at the second abnormality, that the platelet abnormalities. The platelet abnormalities can be quantitative and qualitative. It can also be acquired or inherited. The platelet abnormality, that is abnormality that has to do with primary hemostasis, can be quantitative or qualitative, can also be acquired or inherited. The quantitative platelets, you remember, are small disc-shaped cells that are crucial for forming the initial plug at the site of the injury. Platelet is involved in formation of platelet plug, okay, at the site of injury. And abnormalities that can occur in the platelet is either in the number, when you have reduced number of platelet, that is quantitative, reduced number of platelet, what we call thrombocytopenia, or in their function, which is qualitative, in their function, which is qualitative. So platelet function include, when we talk about platelet function, we are talking about platelet adhesion, platelet activation, and also the release of platelet granules and platelet aggregation. It is this three function, basic function of platelet, that if there is any defect in any of them, can actually have qualitative platelet abnormalities. Qualitative platelet abnormalities. Can and also be acquired or inherited. So let's have a closer look at quantitative platelet abnormalities. Quantitative. Example of quantitative platelet abnormality, what we call thrombocytopenia. Thrombocytopenia is a low platelet count. When you have platelet count that's below 20,000 microliter, you can have spontaneous bleeding. They can have spontaneous bleeding. Now, low platelet counts can be caused by decrease in the production in the bone marrow, anything that can interfere with platelet production in the bone marrow can cause thrombocytopenia, or if you have increased destruction of platelets in the peripheral blood circulation, and this increased destruction can be as a result of autoimmune disorder where an individual develops antibody against its own platelets, causing what we call immune thrombocytopenia. Immune thrombocytopenia can be as a result of individual producing antibody against its own platelet, causing increased destruction of platelets in the peripheral blood, subsequently leading to what we call thrombocytopenia. It can also have increased consumption of platelets in cases of disseminated intravascular coagulation. Okay, when somebody is maybe after childbirth and the woman starts bleeding spontaneously and you end up consuming the whole clotting factors and also platelet, that can cause um, thrombocytopenia in such situations. And another quantitative abnormality of platelets is what we call thrombocytosis. Thrombocytosis and increased platelet count, and of course, thrombocytosis, if not properly managed, can cause thrombotic disorders. And then we have qualitative or functional platelet defects. Remember, I said earlier that platelet function has to do with platelet adhesion, platelet activation, and then release of the granules, and then aggregation. Is if platelet is able to, if you have a good number, the correct number of platelets, the enough quantity of platelet, and then you're able to exert these functions of platelet, then you can be able to form what we call a platelet plug that can block the site of injury when there is injury with the blood vessels. Now, there are different qualitative defects or qualitative abnormalities of platelets. We have the inherited one, those that we inherit, you inherited from your parents, or either your mom or from your dad, passed down, generation, mostly genetic mutated gene. Number one, we have what we call Glanzmann's thrombasthenia. Glanzmann's thrombasthenia. Glanzmann's thrombasthenia is a defect in glycoprotein 2B3A. If you remember very well, that's why I said if you have not watched the video on primary and secondary hemostasis, you need to go back and listen to the lecture so that you understand what we are discussing today well. Now, when we are discussing primary hemostasis, we say that for platelet to adhere to the site of injury, normally platelet has what we call receptors on the surface of the platelet. And then among these receptors, we have what we call glycoprotein 2B and 3A is an integrin receptor. Now, what happens is that activation of this uh, receptor, glycoprotein 2B and 3A, is actually what helps in aggregating, binding adjacent platelets together and then forming what we call platelet aggregation, and at the end of the what we know as platelet plug that actually blocks the site of injury. So for a reason, if individual is having a defect due to as a result of mutation in this receptor glycoprotein 2B3A, then the platelet cannot aggregate. The platelet cannot aggregate, and if platelet does not aggregate, definitely the individual won't be able to form platelet plug. And as such, the person will have tendency to bleed, bleeding tendencies or bleeding disorder. In this particular patient, the platelet count will be normal, the morphology of platelet will be normal, but basically the function will be abnormal. And this particular function we are referring to in Glasman's thrombasthenia is platelet aggregation. The patient lacks the ability to aggregate platelets, form platelet plug. And then we have another inherited disorder of platelet, what we call Bernard-Soulier syndrome. Bernard-Soulier syndrome. Now, Bernard-Soulier syndrome is a defect in glycoprotein 1B complex, another receptor on the surface of the platelet. Now, this receptor is what helps platelet to adhere to the site of injury. When there is injury, platelet normally circulates within the blood circulation. It has no business adhering to vessel endothelium. But once the vessel is injured, the subendothelium is exposed, And this subendothelium contains what we call von Willebrand factor. And then this von Willebrand factor is actually what attracts platelets to the site of injury. And with the help of this receptor, glycoprotein 1b complex on the surface of platelet, the platelet adheres to the von Willebrand factor. And then as it adheres, there is activated to release the granules and also recruit other platelets to form the platelet plug that blocks the site of injury. So where a patient for any reason has a defect in glycoprotein 1b complex, that is glycoprotein 1b 95 complex, therefore there will be impaired platelet adhesion. Platelet won't be able to bind to the von Willebrand factor, and as a result, the individual won't be able to form platelet plug. Having now, this will lead to what? Bleeding disorder. In this case, the culprit is what? Platelet. And the problem here is platelet adhesion, inability of the patient's platelet to adhere to the site of injury or to the von Willebrand factor. And we have such disorder as Barnard-Soulier syndrome. And we have another disorder, inherited disorder of platelet called storage pool defect. Now, this is granular deficiency disorder. Now, you know, when platelet adheres to the site of injury, it is activated. When it's activated, one of the things that it does is that it releases its content, the granules, and that, like I said in that video, the granules that platelet content, number one, ADP, adenosine diphosphate, serotonin, and then thromboxane A2, and then calcium. Now, all these substances that are vasoconstrictors. What do? They enhance the initial constriction of blood vessels to reduce bleeding to the site of the injury. And then the next thing that it does is that it also helps to activate other receptors on the surface of the platelet. When it activates other receptors like glycoprotein 2b, 3a, these receptors will do what? Recruit other platelets to the site of injury. Now, when the platelet lacks the ability to release these granules, then you have what we call storage pool defect, and the individual involved will have tendency to bleed. And we have other inherited receptors like that has to do with the activation. Okay, example, deficiencies in the receptors for collagen, receptors for adenosine diphosphate, or receptors for thromboxane A2. All these things can also cause bleeding disorders that has to do with platelet. Then we have another form of platelet abnormalities. Remember, we are discussing platelet abnormalities. Another form of platelet abnormality that has to do with that's qualitative platelet abnormality. But in this case, it is acquired. It is not inherited. It is that means it is not there before. An individual just gets it in the course of living his life. Okay, we have one what we call drug-induced platelet dysfunction. These are caused by medications. There are some medications that, in the course of their action, they also affect platelet function negatively. One of them is aspirin. Aspirin is a platelet thinner. Okay, so for individuals that are on aspirin, if they are on aspirin, daily dose on aspirin for so long, they tend to bleed if it is not properly monitored. And then we have non-steroidal anti-inflammatory drugs. These things has a way of affecting platelet function negatively, and some antibiotics. And then we have what we call uremia diseases, liver diseases. We have said this before. Liver is the site of production of most clotting factors, and it also has a way of affecting platelets, causing inability of platelets to aggregate. The same thing with uremia. When you have increased uric acid in the system, it also affects platelet function. And then we have cardiopulmonary bypass for individuals that have this type of disorder. It also has a way of affecting platelet function and platelet quantity. And then myeloproliferative disorders. Myeloproliferative disorders like leukemia also has a way of affecting platelets, the quantity of platelet and also the quality of platelet produced in this condition most times are affected negatively. Okay, let us have a closer look at von Willebrand disease. Von Willebrand disease can be quantitative, can also be qualitative. Okay, but Willebrand disease, like we said earlier, affects mostly platelet adhesion. And it does not only affect platelet adhesion, it also affects secondary hemostasis because von Willebrand, number one, it helps platelet to adhere to the site of injury. Then number two, von Willebrand serves as a carrier for factor 8, okay, and also prevents factor 8 from degradation. Now, in absence of von Willebrand factor, where you have defects in von Willebrand, either quantitative defects, that is, it is not enough, or qualitative, it is there, but it's not actually functioning well as a result of either mutation or any other thing. Now, the individual will not only have issues with its primary hemostasis, the person will also have issues with secondary hemostasis because factor 8 is also involved. Let's have a closer look at coagulation or secondary hemostasis defects, defects that can occur in the coagulation cascade or secondary hemostasis. Like I said, this also can be inherited or can also be acquired. It can be inherited or it can also be acquired. So let us look at the inherited one. We have hemophilia A. Hemophilia A is a disease that affects factor 8. It's just a deficiency of factor 8, okay, that causes hemophilia A. And we also have hemophilia B. Hemophilia B is a result of deficiency of factor 9. Deficiency of factor 9 also causes hemophilia B. Now we have deficiency of other factors like factor 2, factor 5, factor 7, factor 10, factor 11, and factor 13. All these ones will cause deficiencies in any of these factors can cause disorders or abnormalities in secondary hemostasis. And then we have the acquired one, just like we discussed when we are talking about platelet disorders. The acquired one has to do with vitamin K deficiency. When you have vitamin K deficiency, remember there are factors that are vitamin K dependent. Factors like factor 2, factor 7, factor 9, factor 10, they are all vitamin K dependent. So when an individual lacks vitamin K, he or she will not be able to produce these factors. And what happens in extension, the person will develop what? Bleeding disorder that has to do with deficiency of those factors that are dependent on vitamin K. And then we have liver disease. Liver disease. Liver is the site of production of almost all the clotting factors, and therefore liver diseases like liver cirrhosis can reduce the synthesis of these clotting factors, leading to bleeding disorders. And then we have disseminated intravascular coagulation. During this process, DIC, there is consumption of clotting factors. And it also, when an individual develop inhibitors, that is autoantibodies against its own specific clotting factors, and so that's what we call acquired hemophilia. Acquired hemophilia occurs as a result of an individual just suddenly on its own develop an autoantibodies against its own factors. In this case, the factor that is affected is factor 8 and factor 9. Then the individual will develop what we call acquired hemophilia. It is not inherited. It wasn't there before. It just came on in the course of the person's life as a result of autoimmune disorder. And then we have some medication that can also interfere with the functions of some of these coagulation factors or clotting, causing their dysfunction. Now we have fibrinolysis abnormalities, abnormalities that has to do with fibrinolytic pathway, the fibrinolytic system. We have increased fibrinolysis. Example in liver disease, perhaps in some other cancers or after trauma, where you have excessive breakdown of clot. Now, clinical features of bleeding disorders. Now, the clinical presentation of these clinical bleeding disorders actually depends on which part of the hemostasis that is affected or that is defective. Like if it is platelet that is defective, now it presents with the platelet abnormalities. If it is clotting factor that are actually defective, it presents with you know uh, defect that has to do with clotting factors. And then if it is that of fibrinolytic system, and then it can also affect that part. So it depends on the part of hemostasis that is defective, or and also the severity of the defect, whether it is inherited or acquired, and whether it is in combination with other modulators like medications, and also whether there is a comorbidity. Now, what are the easy things that you can see to know that somebody is actually having a bleeding disorder? Bleeding disorder, as an example, is easy bruising. You know, the appearance of multiple large and unexplained bruises, what we call ecchymosis. An individual will just, all of a sudden you start having, you just pass a chair, next thing you see him bruising everywhere, tearing up. That easy bruising can be a sign that somebody is having a bleeding disorder. What we call petechia. Petechia is just a small pinpoint red or purple spots on the skin that is caused by minor bleeding from capillaries. And then we have excessive bleeding. That is prolonged bleeding from minor cuts. You have a minor cut on your body or dental procedures or surgery, and the particular place will not stop bleeding. The bleeding will just become excessive. That is a sign that the person might be having bleeding disorders. You have spontaneous bleeding, bleeding that occurs, you know, without an apparent cause, such as frequent nose bleeding, what we call epistaxis, bleeding through the gums, and then blood in the urea, hematuria, or in stool. This can also be a sign that the person might be having bleeding disorder. You have what we call hematrosis. Hematrosis is bleeding into the joint, which can cause pain, swelling, and long-term joint damage, and is a classical sign of hemophilia. When an individual is bleeding into the joint, is a classical indication of hemophilia. Then we have menorrhagia. Menorrhagia, abnormally heavy or prolonged menstrual bleeding in women, can also be a sign that is having bleeding disorders. So, these symptoms that I mentioned, you remember we have the primary hemostasis that has to do with the vascular injury, and then the platelet block formation, vascular constriction or platelet block formation, and then we have the secondary hemostasis that has to do with clotting factors. Now, let's say skin bleeding, petechia or purpura or easy bruising is actually marked in the primary hemostasis, and a patient that are suffering from primary hemostasis is very less prominent in secondary patients that are suffering with any defect in secondary hemostasis. Then when we talk about mucosal bleeding or epistaxis, gum bleeding or menorrhagia, is prominent in defect that has to do with primary hemostasis. It can occur in secondary hemostasis, but it is not very characteristic of secondary hemostasis defects. Then we have bleeding after minor cuts or dental work. Yes, you can have it in primary hemostasis, defect that has to do with primary hemostasis. You can also have it in defect that has to do with secondary hemostasis. Now let's talk about hematrosis or deep muscle hematoma, okay, or large joint bleeding. Is very rare in primary hemostasis. This one is very rare in patients with primary defects in primary hemostasis. It's mostly common in defects in secondary hemostasis. Now, bleeding with surgery or trauma, you know, is usually pronounced in secondary hemostasis, especially after major surgery. And then spontaneous bleeding, joints and all that is not common in primary hemostasis. It's very common with defects in secondary hemostasis. Now, diagnosis. How do you diagnose bleeding disorders? It requires a combination of clinical assessment, patient history, and then laboratory tests. It requires a combination of detailed clinical assessment, the patient history, and also laboratory tests. Now let's look at the laboratory test. The laboratory test we look at is we talk about complete blood counts. And then when we do complete blood counts, we are interested in the platelets, quantitative part of the platelet, talking about thrombocytopenia or thrombocytosis. And then you have another test like prothrombin time test, a prolonged PT, and international normalized ratio can indicate deficiencies in factor 1, factor 2, factor 5, factor 7, and factor 10. And we have activated partial thromboplastin time test. This one tells you about the intrinsic and also common pathway. And a prolonged activated partial thromboplastin time test can suggest deficiencies in factors 8, factors 9, 11, and 12. And also the presence of an inhibitor. We have what the term we call bleeding time test, also using platelet function analyzer too. It's an other test, but it also helps us to assess platelet function and also vascular integrity. It also helps us to assess platelet function and vascular integrity. Now we have specific factor assess like prothrombin time or activated prothrombin time. If they are prolonged, we can go ahead to actually assess for these factors like factor 8, factor 9, factor 11, or for hemophilia A or hemophilia B. Then we have von Willebrand factor studies where we actually assess for von Willebrand factor antigen or von Willebrand factor activity. That will also help us to actually know whether the individual is having bleeding disorder. Now let us look at diagnosis a bit, trying to actually look at what it assesses, different tests I just mentioned, what it assesses, and the typical findings that we see when we do them. I mentioned full blood count. The full blood count includes platelet count and red cell indices. Now, what does it assess? I said it quantifies platelets and also detects anemia and helps us to rule out thrombocytopenia. When you have low platelets, you're having thrombocytopenia. But when you have normal count, it does not rule out platelet function. That means you still need to do other tests to actually check for platelet function. And then we have what we call bleeding time test. Bleeding time test can help us assess platelet function. And also, platelet function analyzer, that 100 or 200 can also help us to assess platelet function, or using platelet aggregometer can also help us to assess platelet function. Then we look at blood smear or peripheral blood smear. The blood smear helps us to monitor, to check platelet morphology, check the platelet size. Are we having giant platelets in the peripheral blood? That means if I having giant platelets in the peripheral blood, that is immature platelets. It shows increased production of platelet, and also it might be a marker telling you about increased consumption too. Also, presence of schistocytes. Presence of schistocyte is also a pointer and also helps us to check for red blood cell morphology. Now, giant platelets is a common thing that you see in Bardet-Solier syndrome. And also schistocyte can also be seen in what we call the microangiopathy. Now we have bleeding time test, like I said earlier, that helps us to assess blood function. And then prothrombin time or an international normalized ratio talks about the extrinsic and common pathway. I've mentioned the factor that they assess, the activated partial thromboplastin time test, also the factor that they assess, factor 8, factor 9, factor 11, and then factor 12. And then thrombin time test. Thrombin time test. Remember that you have the conversion of fibrinogen to fibrin is actually being catalyzed by a thrombin complex. Therefore, when you have thrombin being inhibited, now that final formation of fibrin will not be able to take place. Now, conversion of fibrinogen to fibrin, fibrinogen function, it assesses that particular function and also the presence of inhibitors. And then we have fibrinogen level. You can go straight on to actually assay for fibrinogen level. And then when you have done all these things, you have more specific and advanced tests that you can also do, what we call mixing studies. When I talked about secondary hemostasis, I took time to explain what we mean by mixing studies and how you can actually perform mixing studies in the laboratory. When you have done prothrombin time test on a patient or activated partial thrombin time test on a patient and it is prolonged, what happens? You suspect that a factor is actually deficient. The factor that has to do with this coagulation pathways is actually deficient. Now we'll carry out what we call mixing studies, and mixing studies involve having a normal pool plasma and then mixing it 1:1 with the patient plasma. And then you now repeat the test all over again. When you repeat the test all over again, if it is a factor deficient, it will be corrected. That means the PT will be normal and the APTT will also be normal if it is APTT you're assaying. But if it is as a result of inhibitor, it will not be normal, it will not be corrected. Okay, now I took time to explain it in that particular way. So you go back so that you watch it and so that you know about the significance of the result and how you can interpret the result of mixing studies. Another thing you can do is specific clotting factor assays, going straight on to assay for those particular factors of von Willebrand factor studies, and then platelet aggregation studies using platelet aggregometry. You can also have flow cytometry. Flow cytometry can also help you, to assay for surface glycoproteins, like a glycoprotein 1B complex in suspected Glasman thrombocytopenia disease or Bardet syndrome. You can also carry a genetic test. When inherited disorders is suspected, it's good to carry out molecular studies to identify the mutated genes. Now, you can also have tests for fibrinolysis, example, D-dimer test, plasminogen test, inhibitors of fibrinolysis in appropriate context. And then you have additional tests you can actually do. Simple tests like liver function test can actually give you an indication whether the liver of the patient is actually functioning well or not. Kidney function test, assessing vitamin K level in the individual, and also screen if the person is on aspirin or non-steroidal anti-inflammatory drugs or anticoagulants can also help. And also immunological tests for inhibitors can also help you to diagnose, example, what is going on in the patient. We have some specific examples when we are for cases of hemophilia A or hemophilia A, an individual suspecting to have either hemophilia A or hemophilia B. This individual might have prolonged APTT, and then when you do mixing studies, of course, it will be corrected. And then when mixing studies is corrected, you go straight on to now assay for the uh, specific factor. In this case, if you are suspecting hemophilia A or B, that means the factor should be either factor 8 or factor 9. Then we have von Willebrand disease. In von Willebrand disease, you will have prolonged bleeding time. Of course, because von Willebrand disease has to do with platelet adhesion. Platelets will not be able to adhere, so you have prolonged bleeding time. Or if you do a platelet function assay, it will be prolonged. Okay, and then, but if you do activated partial thromboplastin test, it can be normal if factor 8 is not affected or the defect might be mild there. Okay, then you can go ahead to do von Willebrand factor antigen assay or assay for the activity. And then you can also do platelet function disorder. In platelet function disorder, of course, you will have normal platelet count because the defect has to do with the function, not the count. It is not quantitative, it is qualitative. So in platelet function disorders, when you do your platelet count, it will be normal. Okay. But when you now do bleeding time test or platelet function analyzer, it will be prolonged. That's when you have an idea that what you are dealing with might have to do with platelet function, not actually about the quantitative defect. It is a qualitative defect. It can be as a result of abnormality in platelet adhesion, or it can be as a result of abnormality in platelet activation, inability to release the granules, or it can be as a result of abnormality in platelet aggregation. Okay, and then we have vitamin K deficiency or warfarin effect. In this case, an individual will have prolonged PT or even APTT because those factors that are dependent on vitamin K will be affected. How do you treat bleeding disorders? Bleeding disorders is actually, it depends on the cause and also the clinical contents. But you have key principles. Number one, to stop the bleeding. Number two, to replace what is missing or what is dysfunctional. And then to manage the complication and provide prophylaxis, for those risk. Now we have for general measures you can take. You can, for local hemostasis, pressure can be applied, or topical agents can be used, or sutures can also be used to curtail the bleeding. And then the patient should be advised to avoid exacerbating agents like some drugs like non-steroidal anti-inflammatory drugs or antiplatelet drugs like aspirin. And then if there is liver disease, there is need to address the underlying illness, and also correction of nutritional deficiencies like vitamin K or vitamin C is also in the treatment. But there are also specific treatments in treating bleeding disorder. Like for patients that have a von Willebrand disease, we talk about, you know, desmopressin for many types, type 1 or type 2, or von Willebrand factor replacement concentrate, or antifibrinogen agents. Sometimes the patient can also undergo hormonal therapy for menorrhagia. For hemophilia A or B, we have replacement of the factor that is involved. If it is factor 8, we have factor 8 or factor 9 replacement on demand or as a prophylactic. There's also gene therapy that is also emerging to help to do what? To correct this disorder. We have other factor deficiencies. In other factor deficiencies, you can also do replacement of the missing factor if available. But if this is not available, the person can go on to, we can use plasma concentrate or specific concentrate to augment. Okay, cryoprecipitate. Okay, we have platelet quantitative defects. For platelet quantitative defects, platelet transfusion is appropriate. And then in idiopathic thrombocytopenic purpura, immunosuppressive agents or splenectomy or thrombopoietin, can also, receptor agonists can help in treating specific cases. Now, in platelet function defects, function that has to do with platelet adhesion, platelet activation, and aggregation. For inherited defects, platelet transfusion, can be given in serious cases, and then we have recombinant therapies, avoidance of triggering drugs. Okay, also stem cell marrow transplant is also emerging, but it's very rare. And then for acquired ones, you can go ahead to stop, try to treat the underlying illness. Also, if it is caused by drug, and also an individual might be advised to stop the drug. And then we have like drugs like aspirin that cause thinning of platelets, okay, and also non-steroidal anti-inflammatory drugs, should patients should be advised to stop those drugs, and some antibiotics too. We have vascular abnormalities. Vascular abnormalities, that is, we have usually, it's kind of supportive in nature, and in serious cases, surgery may be prescribed. Then we have acquired inhibitors. Acquired inhibitors, where in cases of acquired hemophilia, that is an autoimmune disorder, when an individual develops an autoantibody against his own factor 8. Okay, what happens in this case is that a bypassing agent is used. Example, recombinant factor 8, that activated factor 8 can be given to the patient so that you bypass the antibody. And also immunosuppressive drugs can also be given to the patient to help to bring down the auto antibody. And we have fibrinolysis. Antifibrinolytic agents like tranexamic acid and amino caprotic acid in massive bleeding like DIC, disseminated intravascular coagulation. It is important to treat the underlying cause. If it is sepsis, the sepsis should be addressed, okay, even while trying to bleeding. There's also in severe congenital bleeding disorders. Example is severe hemophilia. Prophylactic factor replacement is the standard treatment in many settings to prevent joint damage. And then for women with heavy menstrual bleeding, heavy menstrual bleeding, hormonal therapies can also be recommended, or possible tranexamic acid, and also genetic counseling for inherited disorders, and then monitoring for complication, in example to avoid iron deficiency anemia in chronic bleeding. These are my references. Thank you very much. I hope you have learned something today. Please keep a date with us for the next lecture, which is going to be on coagulation disorders. We're going to look at coagulation disorders in details. Thank you very much.